This PowerPoint will review transcutaneous bilirubin monitoring. We will review the benefits, the population of newborns that are included, and the algorithm we will use to test newborns. Additionally, we will review how to use the actual meter, how to document the results in Epic, and we'll provide a brief video at the end of this slide deck on how the meter works. What are the benefits of using a transcutaneous Bili meter? First and foremost, it's non-invasive and pain-free, which in turn causes less stress for the newborn and the parents. Secondly, there are no infection complications, it's cost-effective, and it decreases the potential for iatrogenic anemia. Iatrogenic anemia is anemia that is caused by multiple blood draws during hospitalization. While we only require a small amount of blood to run a bilirubin test, it's a lot of blood for a newborn. On the left of the screen, you'll see a photo of our actual meter that we will be using in its docking station. So which babies are we including in transcutaneous Bili monitoring? All newborns greater than or equal to 35 weeks gestation, including Coombs positive newborns. The only newborns that may be excluded, depending on the physician's orders, are newborns that are transferred from the NICU to 11 Tower. Any newborn transferring from NICU would require a call to the physician to clarify the Bili level plan moving forward. Communication is key, and so is documenting that plan in the newborn's chart. For a non-Coombs positive newborn that is greater than or equal to 35 weeks, you will perform the first transcutaneous bilirubin at 24 hours of age prior to the lab performing the newborn screen. This is important to note because if the newborn's Bili level falls in the high risk category, a serum Bili will be needed, which would be drawn with the newborn screen. The results will then need to be charted in Epic under the newborn procedure flow sheet. For newborns that are Coombs positive or newborns born to mothers who are antibody positive, which we will talk more about later, you will perform their first transcutaneous Bili level at 6 hours of age. If the result is less than 5, a transcutaneous Bili level will be drawn at 12 hours, 18 hours, and then at 24 hours. If the result is greater than or equal to 5, the physician should be notified. Typically, they will order a stat serum bilirubin along with an H&H and a retic count. All transcutaneous Bili results should be charted in Epic. This is the algorithm that we will be following with the information we just reviewed. This algorithm was created by Catherine, Brenda, Heidi, and myself, along with multiple inputs from the neonatologists and the hospitalists. It basically sums up everything into one page and is easy to follow. Our recommendation would be print a copy of this for your reference, especially for the first few months of this new process. For this algorithm, you will start at the top. If the newborn is Coombs positive or was born to a mother with positive antibodies, you will refer to the left and perform the transcutaneous Bili level at 6 hours of age. If that result is greater than 5, you will call the physician and obtain orders for blood work for a serum Bili. This may also include an H&H and a retic count, depending on the physician. If the 6-hour transcutaneous Bili level is less than 5, you will perform a transcutaneous Bili at 12, 18, and 24 hours of age. If at any point the level falls into the high-risk zone on the bilirubin graph, you will notify the physician with the result and obtain orders for further blood work. If your newborn is not Coombs positive, you will obtain a transcutaneous Bili level at 24 hours of age, again, before the newborn screen is completed. Please ensure this happens. The lab will be notified of this change in practice, and we will be asking the phlebotomists to do their best to notify the nurse prior to drawing the newborn screen. However, we're just asking that everyone be as proactive as possible in obtaining the transcutaneous Bili as close to the 24-hour mark as possible. Whatever the result is how you will proceed with further testing if necessary. If the result falls in the low risk category, no repeat TCB is needed. Low intermediate risk, a repeat TCB would occur in 24 hours. High intermediate risk, you will repeat the TCB in 12 hours, and a high risk result would require a stat serum bilirubin. You would then contact the physician with results for further orders. It's important to note that once a serum bilirubin is drawn, the physician should determine how all further bili levels should be obtained, whether that's a serum or transcutaneous. Additionally, once a newborn is started on phototherapy, all bilirubin levels should be obtained serum. A quick lesson on Rh factors and positive antibodies, since we've thrown those at you during this PowerPoint. An Rh factor is a protein that is sometimes found, on the surface of red blood cells. If this protein is present, the person is Rh positive. If the protein is not present, the person is Rh negative. When an Rh negative mother is exposed to blood from her Rh positive fetus, the mother's body may produce antibodies, which can cause a reaction to a subsequent fetus. RhoGAM or Rofalac are immunoglobulins which contain Rh antibodies that attach to the fetus's Rh positive red blood cells to prevent the mother from forming antibodies, thus preventing a reaction to the fetus. This same thing can occur with other proteins. These proteins are called minor proteins. You may have seen them in a mother's history and physical in her charts. Often they're referred to as anti-Kel, anti-Duffy, anti-Kid, anti-Big C and little c, anti-Big E and little e, and MNS. The minor proteins can actually cause a similar immune response, so because of this, it puts newborns at a higher risk of hyperbilirubinemia. We treat newborns that are born to mothers with positive antibodies similarly to how we would treat newborns who are Coombs positive. They require additional testing and closer monitoring. At the end of this PowerPoint, there will be a link to a video on how to use the meter, which will make more sense to you when you actually see the meter. The main points to take away from this slide is that we will be bypassing the ID scanning, so you don't need to do anything with that. The baby ID will always be 1, 2, 3, and you will need to press down on the mid-sternum of the newborn a total of 3 times so that the meter takes the average of those 3 instances. You will see a light flash to indicate it was done correctly. It works best when you wait a few seconds in between each of those 3 times. The final number is the number you will chart in Epic. So speaking of documenting in Epic, in the chart, you will go under the newborn, find the newborn procedure tab, and scroll down to newborn screening. A few lines down, you will see site/transcutaneous bilirubin, which is where you will put chest. You can skip the hours of age section as this will populate in the Bili graph once you enter the results in the next line directly below. In this slide, you will see what is populated to show exactly what should be charted. Again, the site, which would be chest, and then the result you obtained from the meter. Once you enter the site and the result, go under Summary and then bilirubin. You will hit risk zones on the far right side and hover over the teal diamond on the graph. This will show you the transcutaneous results, the risk zone, and how many hours old the newborn is. Lastly, we just ask that you take a few moments to review this video on the use of the meter. We will be asking you to teach back on the use of the meter so that we ensure everyone understands how to use this new piece of equipment. The most important takeaway with this new process is communication with each other, the physician, and the lab. Remember, it's new and it may take time, but communication and adequate documentation in the chart is most important.